Hello and welcome to Individualizing Management Plans for Type 2 Diabetes through Shared Decision Making and Office Hours Activity. My name is Lucia Novak, and I am the president of Diabesity LLC and the co-executive director of Capital Health and Metabolic Center of the Capital Diabetes and Endocrine Associates located in Maryland. Thank you to Peerview for providing the session and to Lily for providing the educational grant for this activity. Throughout the presentation, please watch for additional follow-up polling, and you can submit your questions using the chat feature. I will be answering them live in the chat during the first 30 minutes of the program and live on your screen for the office hours portion in the second 30 minutes. You can view and download today's slides as well as the helpful practice aids on the Peerview website. So before we move on, please take a moment to answer a question on your current approach to shared decision making. So today's webcast was designed to fill gaps exposed by other recent continuing education activities on type 2 diabetes and weight management. And here's what we noticed about primary care clinicians' responses to some questions about initiating discussions for both type 2 and weight and using the shared decision-making process. While many of you answered questions correctly, we did see that some of you were unsure of your answers, maybe due to lack of confidence or just not enough information or knowledge. But we also identified some that were answered incorrectly. For instance, narrowly focused on clinical endpoints rather than the broader clinical context. For instance, you're looking at their hemoglobin A1C, and maybe you weren't realizing that a medication could also be really good to reduce the risk for a heart event or for heart failure, something along those lines. That you really weren't using shared decision making all that much, and you're more likely to rely on personal experience rather than the clinical evidence or the science backed evidence that we use when we're practicing. So therefore, our goals for today, we're going to initiate discussions about weight management and treatment intensification with people with type 2 diabetes who also have overweight or obesity. And hopefully, we will be able to equip you with strategies that will utilize shared decision making and help you to develop those individualized care plans. Starting the conversation. So what we're looking at here on this slide are the ADA, or the American Diabetes Association guidelines, that show that shared decision making is actually an important part, an essential part of developing that person-centered care plan that everyone speaks of when we're trying to help manage type 2 diabetes and actually any chronic disease that our patients might have. And as you can see, it goes around in a circle, and it starts with addressing the patient's key characteristics, thinking about specific factors that might impact your decision as to what treatment the patient may need, but then also using the information you gather from the patient to create a dialogue, a shared decision process where you can both then agree on a plan, implement that plan, provide ongoing support for the patient as they try to continue to implement, and then determining at a follow-up appointment somewhere down the line whether or not the plan that you both agreed on is working and do we need to make any tweaks. So for today's talk, we're going to be focusing on the blue box that identifies utilizing the shared decision making to create that management plan. And when we look at the details that are involved with shared decision making, one of those things is making sure our patients have access to diabetes education and support. So DSMES stands for Diabetes Self-Management Education and Support. And so making sure our patients have access to certified diabetes care and education specialists, certified classes for diabetes education, and registered dietitians who can provide medical nutrition therapy support for our patients. That's just the baseline of what they would need so that they can better participate in the shared decision making with you. And then, of course, we're going to involve not just the patient themselves, but if they bring someone with them to that appointment, a support person, we want to include them as well. And I encourage my patients that if they live with someone or have someone that they rely on to assist them with their activities of daily living or medication taking, that they include that person, invite them to join us, because you could always use an extra set of eyes and ears at an appointment. And then, of course, we're going to explore what the patient understands, what their preferences are, and how we communicate to the patient. Also, want to make sure that we don't call them a diabetic or that they are obese. We want to use patient-centered or patient-focused language. So it would be you have diabetes or you also have the disease of obesity. It kind of gives the person their autonomy and it doesn't assign them a diagnosis as to who they are. And that really does matter. And then talking at the last bullet about motivational interviewing. And I think when people hear motivational interviewing, the eyes just kind of roll back, because we understand that while it is important to do motivational interviewing to involve the patient in the decision process, it's probably a skill that many of us don't use very often. We may not be comfortable with, and we're probably thinking, oh my goodness, I don't have the time. So hopefully I can share with you how I practice, and maybe it can help make it seem less intimidating for you and the patients as well. We know that shared decision making works. So it would not be included as a recommendation in the American Diabetes Association guidelines if there wasn't some research behind it to show that it actually does work. And so this is just one of many studies that looked at shared decision making in a population that have type 2 diabetes. And what we found is that about 38% of the patients that were polled in this particular study perceived that they had some degree of shared decision making with their clinicians. And less shared decision making was associated with the person being older, being male gender, or uninsured. And so, again, we want to try to bring these numbers up because we have seen that when shared decision making is at a higher level or a higher perceived level, there is an increased satisfaction with care. And when patients are satisfied with their care and they feel that they are being included and adequately addressed, them and their needs, they tend to be more open with us. And as a result, we get further with them when we're trying to accomplish certain goals. Shared decision making was not necessarily associated with medication adherence, but it could be just the way that that was measured. I have seen other studies where we have seen a drop in hemoglobin A1C, as well as improvement in depression scores, as well as diabetes distress with patients who feel that they have an open dialogue with their healthcare provider and that they feel that their questions and their concerns were included in the development of the plan. So while we know it's important, it's obviously included in the guidelines. We have data that supports that it is very effective. What's probably missing for most of us clinicians is that there really isn't much guidance on how to involve patients in the shared decision-making process. And so the Mayo Clinic probably has done most of the research that is involved with shared decision making. And they have come up with three approaches. One is to share that information. So, again, and that's a two-way street, the patient sharing the information about themselves once they understand what we are working toward. You know, does what we are presenting to them work in their life? And we are also sharing the information about what the disease process is. what we are trying to help them accomplish, and what therapies are going to be needed to accomplish those goals. The second approach would be patient choice. And so I I proceed with caution here because yes, their patients always have a choice, and no choice is also an option if they choose not to do anything. What our responsibility is to make sure that they are making an informed choice. So if you think of shared decision making almost like informed consent, then you will have a better understanding of what the shared decision making process is. They need to know what the results are of their actions as well as inaction, and what are the realistic options that are available to them. And then they can make a choice. Of course, the third approach is having a conversation. And to me, that would include both sharing the information as well as understanding what the patient's choices are and why their choices may be that way. Before we move on, please take a moment to answer a poll on patient attitudes towards shared decision making. So let's first introduce a case, and this is a woman that is 57 years old, and her name is Anna. She is newly diagnosed with type 2 diabetes, and you saw her for the first time about a month ago. At her diagnosis, her A1C was 8.9%. And at her initial visit, you referred her to diabetes education as well as a registered dietitian to help her with her lifestyle changes that were needed to better manage her diabetes as well as improve her overall health. She did indeed attend the classes and has met individually with a registered dietitian for her medical nutrition therapy. And she has found that using the plate method has been a simple as well as effective way to help her with making appropriate portions and also working on decreasing her intake of ultra processed foods. She is now walking twice weekly for at least 20 minutes, and she wasn't doing that at that initial visit. So now we need to get Anna talking about how she feels that she is doing and what we think needs to be done better. And I will tell you that a patient's ability to want to participate in the shared decision making process is really going to depend not on just how much knowledge they have, but how much perceived power or capacity that they can bring to the appointment. Is their opinion taken seriously? Do they value their own opinion, or are they deferring primarily to what you're telling them to do? So, our goal is to help our patients feel empowered in that encounter so that they can be involved. But there are things that get in the way. And some of the things come from the healthcare provider side as well as from the patient side. So, what I have found, especially in diseases where lifestyle modifications are a significant part of the therapeutic plan, whether that be type 2 diabetes or overweight or obesity management, we have some inherent biases. We're human. We're going to bring those biases to every appointment we have with our patients. It's important that we understand what our biases are because they will translate. And oftentimes, if we're not aware of them, they will not be in relation to what words we are saying, because our body language and other things will convey a different message to the patient. So we want to make sure that we understand what our limitations are and that we address them. You can't get rid of your biases, but you can address your biases, and you can tone the language and change some things about yourself that will actually bring the patient into that empowerment phase and participate in the shared decision making. And as I mentioned, the patient also brings some baggage with them. And oftentimes, what I have come to appreciate, it's not just whether or not they have an income that can afford the medications or afford the appointments, although that is rather significant. But our patients aren't just people with diabetes. They are patients with a full life. And there are so many other things that can get in the way. And if you look at just the cost of receiving care for diabetes, 20% of it is spent on just getting access to us. That doesn't talk about the medications and so on. But they have families and they work and they may be in school, and there's all these competing priorities that sometimes overwhelm the patient and will limit their ability to successfully implement a plan we may have discussed, or from participating in the appointment in general. They may be um, ashamed, they may be embarrassed, or they just might feel like they just don't know how to even begin to talk to us about what's going on in their life. So there are some ways to kind of bring that information to them. And so this slide is showing you from the bottom up. So we would start by engaging the patient. And that, again, is not just by the words we say, it's also by our nonverbal communication. And that would include making sure that the seating in your office is accommodating for people who do have overweight or obesity, that they feel comfortable coming into your office and sitting down. And then using your body language where you're making eye contact and you're leaning forward and listening. And the other piece of that is also, if you ask them a question, and hopefully an open-ended one that they are going to need to think and give you the information that you're looking for, that you pause long enough, because sometimes this might be the first time someone has actually asked them about what's going on in their life in a clinical appointment office. And so don't be in a rush to fill in the dead space of no talking. Allow the patient to process your question and then give them time to answer. I like to use the acronym WAIT, or W for why, A for am, I for I, and T for talking. Why am I talking? Let the patient fill in the void with the question that you have posed them. The next step would then be focusing. I like to ask my patients when they come into the office with me, was there anything specific that they really needed to address today before they leave my office? I may have a whole different plan in mind, but I have come to really appreciate that when patients feel that whatever need they had got addressed, even if I did not get to some of the things I felt were important, they leave my office feeling very satisfied, very heard, very listened to, and they're more likely to come back for their next follow-up appointment and will continue to be engaged. So again, trying to develop an agenda with the patient. They may have some things they want to address, and you can say, okay, and I have some things that I also want to make sure we cover today. So let's get to it. And then, of course, comes evoking, making sure that you are helping the patient to bring forth whatever information you need. And that could be by finding something positive that is going on in their life. So, they haven't taken their medication, they haven't done walking, their diet hasn't been the best because it's the holiday. And I say to them, but you're here today. And that is huge, because they could have chosen not to keep the appointment, as often happens when patients feel that they have not kept their end of the bargain. So I'm always looking for something positive to kind of reassure them that I am on their side with them. And I recognize the difficulty of trying to manage more than one chronic disease. Diabetes seldom comes by itself. There's usually the buy one, get three free, hypertension, dyslipidemia, weight, and then the complications of the weight. They may have bad knees, a bad back, they have sleep apnea, so on and so forth. And again, this is just a piece of who they are. There is so much more to their lives. So trying to get them to talk to us is going to be really important. And then the last thing is, once we've gotten them talking and we've identified some things that are important to them, we have relayed the things that are important to us as far as their management, then we can come together and determine a plan that we both feel comfortable with and that the patient feels able to put into place. So the 4 skills are going to be Open-ended questions, which I mentioned, those affirmations, again, trying to find something positive about what the patient has succeeded with since their last appointment, even if it is just coming in today when they felt that everything was just lost since the last appointment. And then, of course, the reflective listening, validating what they have to say. Oh my goodness, I can only imagine how hard this is for you. You have so many medications that you have to pay for, and you're on a limited income. So let's see if we can't figure out how to better address this. Again, you're listening to them. I see that this upsets you, and you know what? I understand why you're upset. Those are huge, validating the patient, what they're feeling. And then summarizing what they have said. This is what I'm understanding is the issue. These are your concerns. Please let me know if I've misheard you. And then also inviting them to summarize what they have understood from you to have said, so that you can clarify if there was anything. When we talk about obesity management in specific, because it is such a high stigma associated chronic disease, we are actually encouraged, and Medicare wants to see this documented in the chart, that you are using the 5 A's when talking about sensitive subjects, and that includes when you're discussing somebody's weight. And so we would be asking for permission. That's something that seems strange. We don't ask permission to discuss their blood pressure or their cholesterol. They're in our office. We assume they are here for our help. But when it comes to a stigmatizing type of disorder, we do want to ask their permission, because maybe they don't want to talk about it. And what we need to do is at least open the door. We're asking their permission, letting them know that they have the ability to participate in this conversation or not. If they're wanting to talk about it that day, then we let them have at it, correct? Like, we go ahead, tell me what's going on and what you've done that worked and what hasn't worked and what can we try to do better. But if they say, you know what, today's not the day, I just am not ready to talk about my weight, and you can then say, okay, I just want you to know when you're ready, I'm here and we can talk about some things that we can do together, and leave it at that. And I have found that patients will come back and be ready to have those conversations. We are also overwhelmed as healthcare clinicians on different goals that we need to help achieve with our patients. So, what exactly are we looking at? Are we looking at improving their diabetes? Are we looking at reducing their weight? Is it their blood pressure? Is it their cholesterol? So, a lot of competing, again, priorities, but oftentimes they're so often interwoven that if we can address one, we typically do a really good job with addressing the others. And this slide is showing you an example of therapy that we can use that can do that. So certain medications, and you're seeing here a pattern of the GLP-1s and the SGLT2 inhibitors that will help reduce that atherosclerotic cardiovascular disease risk, help improve glucose as well, and not necessarily increase weight for our patients, hopefully helping them to lose weight. So, it's important that we give this information to the patient, that there's a potential that using one or perhaps maybe two drugs, we'd be able to hit many things. What I like about this particular slide is it helps set the stage for when we're talking about weight loss with our patients. People with type 2 diabetes do not lose as much weight as those without diabetes on the same exact treatments that we use for obesity management. And what this slide is showing you is the average weight loss that you can expect when taking these medications. So patients, they seem to think that if I start this drug, I'm going to lose 50 pounds. And that's not necessarily going to be true. Everyone responds to these differently, but this gives us an idea of about how much weight we can at least expect a patient to lose, and then what else we might need to do to help the patients accomplish those goals. And it could be combining agents, it could be referring them for a bariatric procedure, all of those things. So before we move on, please take a moment to answer a poll on goal setting in type 2 diabetes. So when I have a patient that is not comfortable with intensifying treatment or wanting to use a medication, especially when it comes to type 2 diabetes, I will bring up the ominous octet. And the name is going to be changing to Noxious 9. And I think Dr. Stan Schwartz actually has an egregious 11. We keep finding reasons, pathological reasons for hyperglycemia. And the reason I bring this slide up with my patients is to show them there is not a mouth and there is not a foot on this particular slide. And it's not that the lifestyle as well as what they're eating and what they're drinking are not important. I'm trying to focus this less on the shame and blame that often is tied to nutrition and physical activity, and more on the disease process. And just based on this slide alone, there are 8 things outside of how much exercise a person does and what a person eats that contribute to that hyperglycemia. And that is going to set the stage to help me to help them understand why a medication is needed. And patients really do want to know what to expect from a medication, not only the side effects, but I often get, am I going to need to take this for the rest of my life? And I tell my patients, my goal is that you live a very full life with very few complications and on the lowest dose of medication that you would need. So it's going to depend on many things, on what type of medicine and how long they would need it. And again, we as clinicians need to be comfortable with the medications that are available and how to prescribe them and what side effects to counsel the patient on to expect. What I love about this slide is that just as if a patient were on blood pressure medicine and they decided, oh, your blood pressure is at goal, let's stop the blood pressure medication. You don't seem to need it anymore. What we would see is their blood pressure would rise and their hypertension would no longer be adequately addressed. And that is true for just about any disease, to include type 2 diabetes and obesity. So when patients ask, how long do I need to be taking something? I tell them, as long as you have the disorder or the disease, I do not have a cure. We need to do our best with maintaining stability so that you have good health with minimal complications. So now that we've covered the groundwork, let's revisit Anna, our patient that we discussed and I introduced you to at the beginning. And this activity does include some helpful practice aids. And again, you're going to be able to download them from the PeerView website. But let me show you how I would use them to navigate patient-centered discussions to reflect Anna's needs and goals. So today, Anna is in for her first month follow-up with me since her initial diagnosis of type 2 diabetes. She's already been to see the dietitian and she's attended classes. Today, she's expressing concern that while her blood sugars have gotten better, they remain above the targets discussed of less than 120 and less than 180 after she eats. She said she's running anywhere from 120 to 130 before she eats, but it's really her after meals that are concerning her. They're going up as high as 210. And she's also upset that instead of losing weight, she is gaining weight. And she reinforces that she was really hoping to avoid medications. This was something that she mentioned in our initial appointment a month ago, which is why I said, okay, let's get you in to see a dietitian. Let's get you into some classes, and why I scheduled her appointment with me for a month later so that I could quickly intervene and make sure that she was doing okay. So these are her concerns, and now we need to address them. So this slide here is facilitating discussions with your patients about intensifying therapy for type 2 diabetes and weight. So I didn't mention Anna's weight, but most 42% of the adults in the United States have a BMI that's high enough to put them in the obesity category. So it would not be surprising that there was some issue with weight. So while I may not have mentioned it, let's say that she does have a BMI of about 32. So it's not just enough to address her blood sugars, but we also have to think of that comorbidity. On top of that, she's gained more weight. So I'm going to reassure her that the weight gain that she experienced is a natural phenomenon that we see when blood sugars actually get better. And so our goal is that with ongoing exercise that she has implemented and the significant changes to her diet, that will eventually even itself out as her glucoses improve, and hopefully she will start to lose some weight. But I am concerned, as is she, about her post meal elevations. So we'll talk a little bit more about what it is that she's eating, see if there's anything else that we can tweak. But this is where I am going to talk about type 2 diabetes as a disease process, not just focusing on the lifestyle management. And so, again, this is where I will bring up that ominous octet with her. And I will show her that outside of what she eats and the exercise she does or does not do, there are 8 pathological functions inside her body that are contributing to the hyperglycemia. And I can also going to show her some of the medications that we use for managing diabetes. And yes, I will include insulin in this discussion because I never want insulin to be made to feel as a threat or as a punishment. But we'll talk about what the options are, what the benefits are, and go on from there. And so hopefully by the end of that appointment, she's willing to do something in addition to taking a medication to help reduce her risk, to help get that A1C down, and help her live her best life. So before we move on, please take a moment to answer a question on your practice strategies. All right. So, in conclusion, and to summarize, that when you're starting that shared decision making process with your patient, please remember that there are some important things to consider. Not just the patient's point of view, but if they do have a support person in their life that does help them with activities of daily living or management of their disease process, whether it be helping them with meds, have them bring that person in because they can provide some additional insight. And keep in mind that we have tools available, not just for the patient, but also for us as clinicians to kind of help guide us through this process and to really strengthen our skills. And then making sure that we implement strategies that we feel comfortable with to get our patients participating in those shared decision making and understanding that those preferences and those limitations that the patient may have to be part of our consideration when we are developing that plan. We know there are many benefits to shared decision making, and probably the most important of all is the increased trust that the patient will have in us as their healthcare clinician, but also the trust that we now have in them that they are going to be forthright and, honest with what's going on in their life, regardless of what's going on in their life and how it may actually make them feel, that we are on their side throughout the process. So this concludes the formal part of my presentation for today. If you missed the first 2 office hours activities on prioritizing weight management and overcoming therapeutic inertia, please search for office hours on the peer review website to locate these activities. Now it's your turn. Please stay tuned and I will answer as many of your questions and challenging cases as possible. Hi, everyone. I hope you enjoyed the webinar video. This is the portion where I am here accessible to you live. You will continue to enter your questions into the chat, and I will do my best to address all of your questions live. So there is one in the box right now. One of the learners out there says that the biggest problem they face is that their patients tend to think that medications are a cure-all and that they make lifestyle changes unnecessary. What do you suggest as the best approach to get patients to buy into the idea that long-term lifestyle changes are the foundation of therapy to which medications are an adjunct. In other words, how do you combat the attitude that I can do what and live how I want because I can just take another pill or take a higher dose of insulin? So I will say that I have been practicing in the area of diabetes for close to 30 years. And I truly do not believe I've had a patient that actually felt that way. Usually it's the opposite, that they want to stop their medications because they're tired of taking them and they want to try to get rid of the disease on their own. So this is a little bit of a different take. And I honestly do not have an idea of how this happens because I personally have not experienced it clinically. So, but when you have a patient who, regardless of where the disconnect is in what you're trying to impart and what they are wanting to do, is really just trying to meet them where they are and then trying to move them forward. So if you have someone that just doesn't want to exercise, doesn't want to change their diet, and just wants to take more medication, well, fortunately, with the GLP-1 and the GLP-1 GIP combination, it almost forces them to do some of those lifestyle changes because it addresses not just food cravings, but also it impacts how food tastes, their cravings for sweets, their cravings for alcohol. And so there may be some benefit just in the type of medication that we use, but you're not going to be able to do anything for or with or to the patient that they do not want to engage in. So again, just trying to really get to the root of what's going on. Like I said, most people tell me they want to come off all their drugs, not add more to make up the difference. So you ask a very tough question for me. Not many have done that. Any other questions out there? Uh, a learner wants me to describe how I am able to best understand the patient's condition and individual experience. And honestly, that just comes with allowing the patient to tell their story, to ask the question, and to be engaged in their answer. So there's no other way to get to it without letting them share, right? And in order for them to share, they have to feel that they are in a safe place and that you're not going to criticize, laugh, roll your eyes, clear your throat, whatever it is that we do that shows that we are in malalignment with whatever's coming out of their mouths. And we also, we don't have endless amount of time to spend with our patients in an appointment. And so we need to make good use of the time that we have. So making eye contact with the patient, trying not to be in your computer or on your iPad or whatever it is that you use to document the entire appointment. Make eye contact with the patient, greet them, thank them for coming today, because I truly believe my patients can come up with 10 reasons why they did not want to come in for every one reason that they should be coming in. They didn't get their labs done. They haven't picked up the medication from the pharmacy yet. There's been 1,001 things that interfered with them starting their exercise. Instead of losing weight, they gained weight. There's so many reasons why they could not come. So when they do come, despite all of that, that really tells me that they need me to be present in that appointment, and we got to figure out what's going on. Another learner wants to have me explain strategies to overcome weight bias and stigmatization in obesity counseling and decision making? That is such a great question. And it really starts from the time the patient walks in the door of your practice. Does your physical environment that you practice in welcome people of a larger size? Do your chairs accommodate someone of a larger size? Do they have arm on both sides of the chair that they're not going to be able to get into and are going to struggle to get out of? So it starts with little things that we wouldn't even think about. And that, again, is just the physical layout. Is there room for them to get in and out of the door? The toilets, if you have toilets available to the patients to use, whether it's in your office or there's just a public one in the building, are they mounted on the wall or are they floor mount? Because the ones that are mounted in the wall can't hold certain weights. Do you have a scale that would accommodate the weight? Are you weighing the patients in a private area? And are you being discreet? Some patients don't want to know what their weight is. So it has a lot to do with that lead in before you even talk to the patient about their weight, and letting them, if they feel comfortable and they don't feel threatened and they feel welcome, then the conversation actually is easier. We all have our own biases. So addressing your own bias, if there's the Howard University, I think it's Howard, maybe I'm wrong. Harvard, I think it's Harvard's. They have a website that you can go to figure out what your biases are. And they cover all kinds of issues, and obesity, racial discrimination, you name it, is in there. There's many different tests that you can take. It's free, and it helps you to identify if indeed you do have a bias toward people that don't live a healthy lifestyle, toward smokers, toward people who have obesity. And once you identify that you indeed have that bias, you need to know that your biases will come through nonverbal messaging. So what you say is far less important than how you say it and the tone that you're using and your facial expressions. So understanding that you have that bias, you're going to need to start making a conscientious effort to be empathetic, to be compassionate, and to be present for that patient. And that takes practice, and that takes time on your part to identify and also work through it. Someone wanted to know, do not like making changes to their lifestyle. How do we empower them to make changes? So most people don't want to change anything. I also don't want to make a change, and I'm less likely to make a change if it's someone telling me what to do. So for example, if I am complaining about something to, let's say, my husband, and then he wants to give me a solution to my problem and says, well, if you would just do this, blah, 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 blah. I kind of get like, oh, I didn't need to hear that. So I try to think that might be where the patients are also coming from. They need us to help them identify what changes they want to make, what changes they need to make. And so when we're talking about something like exercise, that's a big one for most people. I get, well, it's too cold. And then during the summer, well, it's too hot. And then it's too humid. And then it's too sunny. So they'll come up with many excuses. So we got to find out, well, what's the issue here? What is it that you really want to be working on? Okay. And how can we impart that? So walking, you don't feel safe walking in your neighborhood. Can you do it in your house? Tell me what would be the benefit of you doing that and what would be the consequence of you not doing it. Sometimes having them identify the pros and cons to their own ambivalence is a part of trying to engage them. And we as clinicians need to remember that ambivalence is actually the norm. Most people are kind of like, yeah, I don't really know what I need to do. And Yeah, I know that I'm not living healthy, but I don't know the first thing to change. And, we could come up with a list of things that they need to change right off the bat, but it's not for us to impart that list. We can give them some ideas like, well, we need to work on physical activity, changes to nutrition, maybe keeping some appointments or making some appointments that you haven't been keeping. Where do you feel you want to start? What's the easiest thing for you to tackle? I kind of approach it in the same way when you're talking about debt. If you knock off the lowest debt credit card first and then work your way up, you kind of chipping away. So trying to find a way that it's not overwhelming for the patient is huge. How do I manage a patient with severe insulin resistance requiring U500 insulin who is intolerant to a GLP-1 agonist and an SGLT2 inhibitor and has to lose weight? For those of you who may not know, we no longer are going by the ominous octet that Ralph DeFranzo coined back in 2008, I think it was, 2005 maybe, the ominous octet. And that talked about the 8 pathological issues that were occurring within a person's body that contributed to hyperglycemia. And it didn't include, exercise or what a patient ate. It was just physiological things due to that insulin resistance. Well, now there is the noxious 9, and the noxious 9 now includes hypercortisol. So the recommendation really is if you have a patient that has type 2 diabetes, which such severe insulin resistance that they require U500 insulin and cannot take the newer meds that we have that can help with the weight, we are encouraged to do dexamethasone stimulation tests to find out if hypercortisol is part of their pathology. For those patients that really need to lose weight and they can't take the medications, we really need to be discussing the option of bariatric procedures. And a lot of people just, oh, I'm not doing surgery. That's the last resort, blah, 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 blah. But you know what? It is an effective therapy and it is a life-saving treatment for so many of our patients with class 3 and higher categories of obesity. So we really need to get them at least open to discussing and referring them to a qualified bariatric surgeon. With a starting dose of 2.5 milligrams weekly, is it necessary to start this low when a patient switches from another GLP-1? So that is going to depend on why the patient is switching. So if the patient is switching from another GLP-1 because they had problems tolerating that GLP-1, even if they handled the lower doses and then they got to a certain dose and didn't do well, I highly encourage you start from scratch with whatever GLP-1 you are switching them to. If it's because they kind of have plateaued, their A1C is not dropping any further, their weight has kind of plateaued, and you're trying to put them on a more aggressive therapy, then you don't necessarily need to start at the very lowest dose. So you could start, with a 5 or a 7.5 milligram if they were on the 2 milligram of semaglutide, switching them to the tirzepatide. You could go a little higher. That is off label. That's not what it says in the labeling. I'm bringing you my own clinical expertise. So it really depends on why. If there's a reason that their insurance stopped paying for it, then we can do a dose equipotent if they didn't have any problems. Sometimes patients are off meds for several weeks because of supply issues. And sometimes, even if we're not changing their GLP-1, we're just getting them back on. If they've been off med for 3 weeks or more, you may need to start them at the lower dose, not the lowest, but let's say they were on 10 milligrams of tirzepatide. They were off drug for a month because of supply issues. Rather than just ramping them back to the 10 milligram, I might start them at the 7.5 or even the 5 and then wrap them up again. We really want to make sure that they are able to tolerate these drugs. I have seen far too many patients fail treatment because they were ramped up too quickly, and then the side effects kind of caught up to them. So there's no rush, and there's really no reason to be rushing through these drugs. Patients will benefit with every dose that they're on, and they will do better in the long run if we move slowly with them. How to encourage the tapering up of the dose without side effects. So that's a great question. And again, it really means just slowing down, not being in a rush. Just because you can increase a dose every 4 weeks, that's how it was done in the study, because they were trying to get them to the maximum dose to then see what the endpoints would be. That's not how we practice, right? So I have patients that can be on a dose for as long as they are A, tolerating it, and B, responding to it. So they could be on a 0.5 dose of semaglutide for 6 months before we need to go up. So again, take your time with the up escalation of the dose, and also help patients know what they're going to be experiencing. The nausea, the vomiting, well, not so much vomiting. It's really more the nausea and then the change in the bowel habits. I'm more concerned about the constipation, because that can really set up for some significant issues if we don't get on top of it. So having them be aware that they're going to have satiety sensations that they may not be used to, that because their gut is slowing down, they're going to fill very quickly. If they develop constipation, they really need to do a good job with hydration. We really need to be encouraging increased fiber. And I do not recommend Metamucil or Benefiber. They need to be getting that fiber from fresh fruits and vegetables as much as possible, because the Metamucil and other products like that, when it is a drug-induced slowed motility, those products can actually form a brick in the colon, and it could really make the constipation worse and could lead to an impaction. So hydration, ambulation, natural fibers in the diet that they are eating, as well as using things like Marilax or Senecot or Dulcolax, something that gives them a little bit of stimulation, because it's a drug-induced slowed motility that they're having the constipation. So those are all things that I counsel my patients on, and making sure that they understand. And then I have my MAs. Like when I start a patient on a new drug, or I increase the dose to the next level, even though they may not be seeing me right away. And I tell them, if you have any questions between now and the next appointment, please reach out. I will still have my MA reach out to patients that I feel need a little bit extra eyeballs on, just to kind of touch base with them. Hey, Miss Novak wanted me to check in on you. Is everything going okay? Are you experiencing any side effects? And you'd be amazed at how many say, oh yeah, I was meaning to call you and, kept forgetting, whatever. So engaging the patients that you think need that little bit more of extra hands-on is important. I am concerned about potential harm from long-term use. How much has this been studied? I'm assuming you're talking about the GLP-1 GIP. So keep in mind that the GLP-1 receptor agonists have been available in the United States since 2005. We have more and more and more data that actually supports that long-term use is safe. At least based on the data that we have since 2005. In 2008, every drug that was brought to market for the management of diabetes had to undergo very strict cardiovascular outcomes trials to prove that they were not going to increase the risk for harm in patients who were either very high risk for having a cardiac event or have already had one, and their risk for having another was also very high. So, and in addition to that, both here in the United States and our colleagues across the ocean have been keeping, what do you call those? I can't even think of the word, but they've been keeping like a directory or some kind of repository where they're monitoring long-term effects to make sure that medullary thyroid carcinoma is really not something that is something that we need to be worried about. The more we learn about these drugs, the more we are understanding how much more beneficial they are than harmful. So it has been studied. It continues to be looked at. The longer and more patients that we have on these drugs, the better. In which patients would you go directly to tirzepatide instead of starting a GLP-1 first? Well, there's nowhere that says you have to choose a GLP-1 first before you can use tirzepatide. The only place that actually would be a directive is probably insurances. They want you to do, the patient has to go through step therapy. But if, let's say, the playing field is equal and I have access to both a GLP-1 and the tirzepatide. So I need to know, well, what data do I have about the drugs currently available and what data do I have about the patient? So right now, tirzepatide has been approved to treat sleep apnea. We're still waiting on its cardiovascular outcomes trial data that has not come out yet, and they do not yet have that FDA indication to reduce the risk of MACE. So in those instances, if I have to choose, I might lean toward a GLP-1 that does have that FDA indication, that has the proof from the studies that were done. So that could be dulaglutide, liraglutide, or semaglutide injectable. If all things are equal and I really don't necessarily have a preference, tirzepatide is a great drug. It tends to be a little bit more potent than just the GLP-1 because it is a combination agent. And it also appears to be a little bit better tolerated because of the GIP component in it. So there's no wrong answer using GLP first, using GIP, GLP. It's really whatever the patient has access to. And again, if I have to choose and the patient has access to either, I'm looking at, well, what else besides diabetes am I really trying to address? And if there's cardiovascular, semaglutide has also showed that it is beneficial for heart failure in people with obesity. So again, we're learning more and more about these drugs, and so we may use those indications to help us decide what to use. What is the most effective beneficial exercise regimen to incorporate with GLP-1 to increase success? Is it cardio, strength, both? How often? Great question. So what we worry about with these drugs, because of how they impact the appetite, and our patients are not eating, and so we really get into trouble with potentially having them develop sarcopenic obesity, which is muscle wasting and loss of muscle strength. So sarcopenia is usually something that we worry about in our elderly patients. As we get older, we lose lean mass, and that's an indicator for morbidity as well as mortality. But we're also seeing this happen in people who lose weight, especially when that weight loss is pretty significant and very rapid. They're not just losing fat, they are also losing muscle. So it's important to counsel our patients that, yes, I know you're trying to lose weight, and these medications really do knock out the food noise, and you don't have an appetite. You can go all day without eating, but they can't really drop below 1,200 calories a day, because then they are in a starvation mode. So they've got to find ways to get in enough calories. So I try to counsel my patients not to go less than 1,200 calories. And they need to get at least 60 to 90 grams of protein every day. And then the physical activity that is very important is really going to be strengthening exercises. That's not discounting walking and other aerobic type exercises. Both are actually needed. But when it comes to maintaining muscle mass, especially for women, because we don't have testosterone, and after a certain age, we start to lose our best friend, estrogen. So the strength training is really important. And those can be with calisthenics, meaning your own body weight, lunges, planks, crunches, glute bridges, you name it, those kind of exercises, push-ups off the wall. Last question. Why does the weight loss rapidly return after discontinuing semaglutide or tirzepatide? The weight loss will rapidly return regardless of what you use to lose the weight. So if you were counting your calories and you put yourself in a caloric deficit, and that's the only mechanism that you use, and you lost 30 pounds, the minute you take yourself out of your caloric deficit, the weight will come back. And that is also true with these medications. We do not have a cure for obesity, just like we do not have a cure for hypertension. We don't have a cure for dyslipidemia. We don't have a cure for many of the chronic diseases that require ongoing treatment. Even when patients achieve a goal, we don't stop their blood pressure medicine because they got a blood pressure of 120 over 80. We know that if we do, their blood pressure will go back up. And if we start thinking along those lines, we will understand the significant barriers that patients face when they're trying to achieve a healthy weight and then maintain it. I believe that was the last question that I have time for. You guys have been absolutely fantastic. Thank you so much for being so engaged and asking me all these great questions. And I wish you all well. And I hope that you will start practicing engaging with your patients, allowing them to tell their story when you meet with them.